This is a narrated PowerPoint to accompany the Humans chapter, Brain Tumor Outcome Studies, Design and Interpretation, by myself, Fred Barker, and my colleague Dan Cahill. There are many excellent texts on general clinical study design that are available, and those issues won't be covered in this chapter, which is going to focus on issues in design and interpretation of clinical studies specifically on brain tumors. Most brain tumor outcome studies currently are multidisciplinary, but this chapter will principally be focused on issues in trials that include surgery. Defining the patient population is the first task when writing a paper on a brain tumor clinical study, designing a study, or interpreting a study. Age is particularly important in glioma studies. It's an important factor in the prognosis of many, perhaps most brain tumors, and can act as a surrogate for different molecular pathologies, for example, IDH mutations, which are frequent in young patients with glioblastoma. Histology. Nearly all brain tumor studies are limited to a single histology. Definitions often change over time, such as the WHO meningioma grading system, which has changed several times over the last 20 years. And histology grading systems may not be consistent between different pathologists. Modern systems often include specific genetic classifications, and the WHO is moving more toward this with time. Studies that can include patients without surgical histology, such as radiosurgery studies or whole brain radiation studies, need to be interpreted in view of the lack of definite histological diagnosis and the possibility of misclassified patients being entered in the study. Baseline risk classifications are a common stratification factor or even entry factor into many clinical brain tumor studies. Some common histologies may be described in terms of a baseline risk score, such as the RTOG recursive partitioning analysis for malignant glioma, or the RTOG graded prognostic assessment for brain metastasis studies. These scores only remain valid for patient cohorts that share diagnostic, prognostic, and treatment characteristics that resemble those in the original cohort from which the risk score was developed. So, for instance, if the cohort is limited to radiosurgery eligible patients, the RTOG RPA may no longer be valid. Other important characteristics of patient sets can include functional status, specific neurological characteristics such as hearing status for acoustic neuroma studies, systemic disease status for studies on brain metastases, and so forth. Describing treatment. An important characteristic of treatment that needs to be described in many brain tumor surgical studies is extent of resection. This varies typically by both diagnosis and sometimes from study to study. When tumor volumetrics are available, resection can be described either by the percent of the tumor that has been resected or by the amount of remaining tumor volume present on postoperative imaging. Exactly what MRI volume is relevant varies by tumor histology. So for glioblastoma, the enhancing T1 volume is usually used, whereas for lower grade gliomas, IDH mutant gliomas, T2 bright volume or flare bright volume may be chosen. Some histologies have special definitions, such as the Chang criteria for medulloblastoma studies and the Simpson criteria for grading meningioma resections. Describing outcomes, the choice of endpoint. Many endpoints are used to describe outcomes in cancer studies, and endpoints for both efficacy and safety are necessary for almost all studies. Survival is usually used in brain tumor studies, or often used. Operative mortality, which is usually defined as 30-day mortality, but when studies use an administrative database as the data source, they may substitute in-hospital mortality because of the limitations of the database. Overall survival is an important outcome in many situations, particularly glioblastoma, but may be less important if survival is driven by other aspects of the disease or the patient's health status. For instance, most death in brain metastasis studies is from systemic disease progression, and in benign tumors, particularly those that occur in the elderly, such as meningioma or acoustic neuroma, overall survival may be only loosely linked to disease progression of the primary benign tumor. This can also be affected by subsequent treatment in some cases. Progression-free survival is used in situations like this, and in this, definition of progression is key. Other time-dependent outcomes can include independent survival, which is often used in brain metastasis studies, time to neurologic progression or death, similarly emphasized in metastasis studies, or time to regional failure, meaning failure elsewhere within the brain outside the original resection site, or distant failure elsewhere within the body. These are common in metastatic studies as well. Quality of life is defined using many different outcome scales and scores, such as general scores like the SF-36, or disease-specific scores such as the SNOT for endonasal tumor studies. Neurocognitive function is important, especially when treatment toxicity may affect function, as often after whole brain radiotherapy for metastasis or lymphoma. Functional scores like KPS are commonly used, but missing data is an important limitation when quality of life is measured over extended periods of time after the initiation of the study, and dropout is rarely at random, in that tumors that cause functional decline cause dropout at an accordingly increased rate. Tumor response rate. Different measures of imaging response are used for many brain tumor histologies, just as they are for extent of resection. And for some histologies and for some specific treatments, a RANO response in neuro-oncology classification may be available. For most benign tumors, no universally recognized standards have been defined. Duration of response is as important as response rate in many situations. Confounding factors such as steroid dose may be important, and some tumor imaging responses do not actually reflect anti-tumor activity, but may reflect the reconstitution of a more normal blood-brain barrier. This seems to be the case in bevacizumab studies. Finally, toxicity. The NIH common toxicity criteria are often used to grade and express chemotherapy toxicity, but may not be as equally applicable in surgical studies. The NIH stroke scale or a decline in KPS may be used to express new deficits after surgery. Special considerations for early phase trials. This would be phase 0, phase 1, and phase 2. Given the small number of patients that are typically enrolled in these trials, ascribing complications to surgical therapy may be difficult. For example, in defining the expected frequency of seizures after glioma surgery when the experimental agent is implanted during the operation. Most modern brain tumor trials use a time-dependent endpoint such as survival or progression-free survival, and randomized phase 2 designs are usually necessary due to difficulty defining an appropriate historical control group. Special efficacy endpoints like tissue drug levels or biological endpoints in phase 0 trials may be necessary. For phase 3 trials, challenges in feasibility include defining a patient group with equipoise and selective dropout in the control arm if effective blinding is not possible, standardizing special procedures such as catheter placement in CED between different surgeons, and the rapid evolution of new technologies with the possibility of premature adoption of new technology as, quote, standard, for example, the use of intraoperative MRI. These factors may make generalizing trial results to other patient populations difficult or even inappropriate. Pitfalls specific to extent of resection studies. Not all patients are candidates for a safe total resection, and thus resectability may itself be a prognostic factor. For example, more resectable glioblastomas in the frontal pole are much more likely to have IDH mutation, while less resectable tumors located in the thalamus are more likely to have the K27M mutation. And when the specific mutations are themselves prognostic factors, this becomes intertwined with the concept of resectability. Randomization is one solution. Others include adjusting for resectability or eloquence of involved tissue, or studying adjuncts that improve resectability, such as 5-ALA treatment in tumors that are candidates for gross total resection according to treating surgeons. Pitfalls: recurrent tumor studies. Studying the efficacy of a therapy administered at recurrence cannot use survival beginning at diagnosis as an endpoint. This is statistically invalid and should never be done. Patients in both treatment and control groups must be eligible for the treatment, as the eligibility itself, as with resection, may be a powerful prognostic factor. This was proven for brachytherapy in recurrent glioma, where phase 2 trials showed encouraging results, but randomization found no actual effect on survival. Health service research studies are another class of important studies. These include studies of aspects of healthcare delivery, and in many cases study socially defined factors that are not intrinsically randomizable. Examples would be volume outcome studies, studies of the effect of specialist care, and disparities studies. These are often performed using administrative databases, and the lack of randomization as well as the lack of granular clinical data must be considered in interpreting results of these studies.